Hello everyone. Today we will be discussing regarding the NEET-SS previous year's questions, recall questions pertaining to gynae oncology. So a few disclosures at the beginning. As you know, these are all recall questions, so many of these questions might not be complete regarding the entire question body or in the number of options. But we'll try to our level best to actually devise methods to how to approach these questions and what could be the correct options there. And with respect to the theory part of the question, what they intend to cater to. There are a few questions that are might not be directly related to gynae onco per se, but then because they actually feature in these questions, we would be discussing a few of them also. So let us move right into the questions. So comparatively simple kind of a question. Patient with amenorrhea, vomiting and grape-like vesicles and ultrasound showing cystic fluid fill spaces and snowstorm appearance. So the question itself carries the all the terminologies that are pertaining to the hydatidform mole or a molar pregnancy. So that is actually an easy question there. What we need to understand is why do you have this snowstorm appearance is because of the uterus that actually gets filled with the trophoblastic tissues, and then there are a lot of micro hemorrhages happening because of this rapidly proliferating tissue, and the hemorrhages that happen occur together within them, and these hemorrhages coalesce together, and this actually gives rise to the cystic fluids filled spaces. And it is this presence of both the what do you say, the hyperechoic trophoblastic tissue interspersed by the blood filled spaces that gives rise to the characteristic snowstorm appearance in the ultrasound. So the next question is 22 weeks pregnant lady who underwent conization for cervical carcinoma and with negative margins. So what should you do? So this is again a question that is pertaining to cervical cancer in pregnancy. It's a very important area from where you can get questions during your exam because you have set algorithms for them. And again, what you should look into it whenever you get a question regarding cervical cancer in pregnancy is you look at what is the stage of the disease that is mentioned, if at all is mentioned. I'm not sure whether the stage was mentioned in the exact question paper back then. Then period of gestation, and also whether the patient wishes to terminate the pregnancy or not, or whether she wants to continue. So the entire management of cervical cancer in pregnancy actually depends upon these main features. So again, depending upon the stage, so even if the stage has not been mentioned directly in the question here, you can see that the patient has undergone a conization. So mostly you do a conization for of cervical cancer where you don't have an obvious growth seen on the cervix. So it is unlikely that the patient is already having a large macroscopic tumor there. So it could range anywhere between 1A to 1B1 there. Okay, and in these cases, you might have done a conization then and there. And when the conization is already done and the margins are negative, so that pertains that it's mostly a microinvasive cancer. And once the margins are also negative, and they have not mentioned whether the LVSI are actually present, but if the LVSI are also absent, in that kind of a condition, the cervical cancer is said to be treated also. So this is the management of cervical cancers 1A1 without LVSI. You do a conization, okay, and if negative margins, you may actually stop. If you have a case where if there were LVSI, and then the presence of LVSI actually denotes that there could be possibility of lymph nodal involvement. So LVSI, look for lymph node involvement. So what will you do for that? You will have to again subject the patient to a laparoscopic pelvic lymph node dissection. So here comes the importance of having the cutoff of the gestational age. So usually you have different guidelines which actually give cutoff of 22 to 24 and even in some conditions 25. So the 22 to 24 weeks gestation cutoff is actually for those patients where the pelvic lymphadenectomy that is to be done by laparoscopy, the feasibility of doing that with a gravid uterus inside your abdomen, the ability to reach the pelvic areas for the lymphadenectomy, that becomes more difficult when you have a pregnancy that is beyond 22 to 24 weeks, and that is why you have this cutoff in many guidelines of this 22 weeks or not. So again, if you have a patient who has had a conization, LBSI is positive, let's say that, and then you wanted to evaluate the lymph node the condition or the staging of the patient, because once the patient is having a positivity of lymph nodes, that itself points towards a stage 3C, that means makes it more advanced. Then you'll have to think about termination of pregnancy or not. But then all that could be unlikely because you already have a colonization done and the margins are negative. So of the two combinations that have been given as options here, whatever treatment you require, you can delay it till delivery because you think that this is somewhere between 1A1 or 1A2 and highly unlikely that it's 1B1. But if it is colonization done and the margins are positive, that means it is a case of 1B1, even if it is microinvasive per se, but the margins positivity actually makes it 1B1. There, your treatment is not complete with the conization alone. You might have to even think about going for a simple trachelectomy at least, along with the pelvic lymph node dissection. So if you have done conization, margins are negative, you think it is somewhere between 1A1 to 1B1, and the patient has already crossed the period where you can actually effectively take out the lymph nodes, and the patient wishes to continue the pregnancy in that condition, keeping that you have already removed the tumor out of her body, you can actually delay till the delivery. So actually speaking, if you had another option of no further treatment required or patient to be kept under follow-up, and if you're sure that this case is a 1A1 without LBSI, then this conization itself is treatment for her and she can be kept under follow-up afterwards. If she falls into the spectrum of 1A1 or with LBSI to 1B1, anywhere between that, you can actually delay till delivery because the colonization margins are negative. So look at the stage. Here we think that the stage is stage 1A1 without LBSI. Then look at the period of gestation and also whether what is the wish of the patient, whether she wishes to terminate or continue the pregnancy. So always go through the different algorithms for the CA cervix in pregnancy. And remember, you'll always have to keep the option of termination of pregnancy first if you have a advanced case. That means you have lymph node positivity or any of the lesions that are more than 1B2 to up to 4B. But then if the patient is not willing for termination of pregnancy, then the next best option that you would like to give would be neoadjuvant chemotherapy, especially you start that in the second trimester onwards to avoid the period of organogenesis in the first trimester. So chemotherapy is actually considered safer during second trimester and the third trimester, and you give it up to maybe about 35 weeks of gestation so that you get at least a 2 to 3 weeks gap between the last chemotherapy dosage and delivery, so as to avoid the complications associated with you have patient getting having very low total counts and having issues related to that when the patient undergoes a delivery or a surgical approach for her delivery. So these are two options when you think about in terms of an advanced disease, whether you go for a termination of pregnancy or a neoadjuvant chemotherapy. And then depending upon the final stage, at the time of cesarean delivery, would you actually advise a radical hysterectomy along with cesarean delivery? This is when you have those tumors where radical hysterectomy is the treatment of choice. But then if you have tumors that are beyond 1B2, that is from 1B3 onwards up to the advanced stages 3 and 4, then you would actually want the patient to undergo the concurrent chemoradiation, and that would be actually given after the delivery. So again, if you have a patient who has undergone colonization after cervical cancer, what would be the mode of delivery? Usually, for cervical cancer, we think in terms of cesareans, but vaginal delivery is a possibility when you have a patient who has undergone colonization and there is no residual disease. So, as we discussed in the previous question, if there is a patient who has undergone colonization and there are negative margins in them, that means there is no residual disease present there, then in those conditions the patient can have the option of vaginal delivery. But in any kind of a cancer where there is presence of residual tumor in the cervix, and if you let the patient go for a vaginal delivery, there is a risk of, again, vaginal delivery related problems like the bleeding and then dissemination of the tumor. That is what is most worrying for the oncological perspective. And there might be, again, metastasizing of the cervical tumor into the vagina, onto the vulva, episiotomy scar and all that, and that will again aggravate, upstage the disease and make the prognosis dismal. So you avoid vaginal delivery in any patient who has already got a bulky tumor or who has undergone a treatment like a colonization or a trachelectomy and there is still residual disease present. A trachelectomy patient, usually after the cerclage and scarring delivery, if the patient has not gone in for a preterm delivery, sometimes because of the scarring and presence of a higher up cerclage, sometimes vaginal delivery can be difficult. But as long as there is no residual tumor, the patient can undergo vaginal delivery. Otherwise, in all cases of cervical cancer, the preferred mode of delivery is cesarean, and especially if there is a bulky tumor in the cesarean, you actually prefer a classical cesarean section in these patients. So for post-colonization negative margins, vaginal delivery is the better option. Now we have a case here who is a 45-year-old Paris lady who had presented with abnormal uterine bleeding due to leiomyomas and an 18 weeks uterus. So it's a large uterus, 45-year-old, multiparous, multiple FIGO 4 and 5 fibroids, the largest 8 into 8. She has no other family history of any malignancies, and the DNC has shown secretory endometrium. So what would be the best management for her? So this is again, she has been having heavy menstrual bleeding with multiple fibroids and a 45-year-old Paris woman. So if, as we feel that she has already completed her family and her bleeding is the main symptom here because of these multiple fibroids, the best option for her would be actually a hysterectomy through any route which is actually feasible for her. Here, because we have been given the options of TAH, we'll go ahead with the TAH option. But then again, you have three sub options for the TAH. Is it TAH with BS or TAH with BSO? So again, the BS is the bilateral salpingectomy, and then the TAH with bilateral salpingo-oophorectomy. So then, or just plain TAH by preserving the tubes and ovaries. When you have such kinds of options, then here the the examiner is actually trying to test you regarding the options of what you call opportunistic salpingectomy. So although there are RCTs going on now, you have lots of case controlled and population based case studies and retrospective cases that have actually brought into a lot of systematic reviews and meta-analysis, which have shown that opportunistic salpingectomy means when the patient is undergoing any kind of a gynecological surgery, or even non-gynecological surgeries also, they also come under the purview. So, and for examples, the patient undergoes a tubal sterilization or for any other benign gynecological conditions. In those cases, the tubal sterilization, what we usually do is actually the tubal ligation according to the modified Pomeroy's technique. That is what is actually being promoted under the government scheme in India. So rather than doing the tubal ligation, you go for the removal of both the fallopian tubes entirely. So that is called salpingectomy, and you are doing it at a point when you get an opportunity to intervene or enter the abdomen of the patient. So again, when the patient undergoes a hysterectomy for fibroids, as in the case that is already mentioned, when you get a chance for that, you can also remove the tubes, salpingectomy in this case also. And when you do such kinds of salpingectomies in these clinical conditions, that is when you call them opportunistic salpingectomy. Why do you want to do this? This is actually to bring down or reduce the risk of, you should always be aware, tubo-ovarian cancers. How do you bring down the risk of tubo-ovarian cancer? By doing a salpingectomy. So you should be aware that the most common histological kind of ovarian cancer is the high-grade serous ovarian cancer. And the precursor lesion of the high-grade serous ovarian cancer, although they are part of ovarian cancer, the precursor lesion lies in the fallopian tube, especially in the fimbria, that is the stick lesions, serous tubal intraepithelial carcinoma. So once you remove the fallopian tube as such, you bring down the risk of these stick lesions, even if they are present, of them getting disseminated onto the ovarian surface and then later on giving rise to the ovarian tubal and the peritoneal carcinomas. So from all these systematic reviews and meta-analysis, it has been found that opportunistic salpingectomy brings down the risk of tubo-ovarian carcinomas at least by 40 to 60%. So at least there is a 50% reduction in a patient. And again, you should remember these are for the average risk women. Average risk means she is not at a higher risk of developing tubo-ovarian cancers due to any of her genetic mutations or due to any family history. So again, the importance of that in the question can be seen. She does not have any family history of any malignancy. What if she already had a family history of malignancy, or she had any kind of genetic predisposition to it? She becomes a high risk candidate. So for a high risk candidate, as we said, for average risk, we will give opportunistic salpingectomy. For the high risk candidate, especially if they are known carriers of the BRCA1 and 2 mutations, or she's got a very strong family history of breast cancers or ovarian cancers or any BRCA related cancers in the family, then the risk reduction surgery is what is to be done. This is not opportunistic alone. You have to advise them that they have to undergo a prophylactic surgery, and that is called a risk-reducing salpingo-oophorectomy. And as of now, risk-reducing salpingo-oophorectomy is what is advised for the high-risk individuals. But when you discuss regarding average-risk individuals, when you get an opportunity to intervene or get into the abdomen for the removal of the uterus, or for any other non-gynecological procedures, like a patient who is undergoing laparoscopic appendicectomy, if you want, you can actually counsel the patient regarding, along with this procedure, would you want to have a undergo the opportunistic salpingectomy along with that, and then do that. And this is basically to bring down the risk of tubo-ovarian cancers, but you do not fully eliminate the risk because you are still leaving behind the ovaries for their function, and that is actually required in those patients, especially if they are premenopausal. So this is the concept of opportunistic salpingectomy, and I think that might have been the main governing factor behind that particular question there. Now you have again your AAA, that is the European Guidelines for CA Endometrium 2025. Please have a look into these guidelines so that you actually prepare well in advance for these kinds of questions. Again, this is also similar to what we had seen in the FIGO 2023 CA endometrium staging. And now what we need to understand is, what do you mean by the different risk stratification for endometrial cancer? You have the low risk, intermediate risk, high intermediate risk, and high risk. And where does the patient in this question, where does she lie? Again, I'm not sure whether all the questions are actually complete in this, because when you look at the staging part, the endometrioid carcinoma, who is grade 1 and less than 50% myometric invasion. Up to that, it actually denotes 1A2 according to your new FIGO 2023 classification or staging. So 1A2, but her molecular classification is P53 mutated. So P53 mutant again makes it a molecular classification of the high risk variety. So she automatically becomes 2C molecular P53 abnormal. So any of these patients who are 2C P53 abnormal mutated, they automatically become high risk group. So as per your staging, you should be aware thorough when do they actually become high risk and when are they low risk and intermediate risk and high intermediate risk. And as we already know, low risk is usually observation, intermediate risk is usually vaginal brachytherapy, high intermediate risk is EBRT, and high risk is usually your EBRT with chemotherapy, either concurrent chemo radiation therapy with chemotherapy or sequential. So we didn't have a option like that in the above mentioned option. So maybe if there is an option for a chemotherapy along with that, that would be the preferred regime, as this actually comes under the higher risk population. If you don't have any option with chemotherapy, at least the EBRT with vaginal brachytherapy is what is actually needed in your setting. Again, there are actually options based upon the age of the patient and then to de-escalate the treatment, but that is more individualized kind of a discussion after a multidisciplinary team planning, and that is more in terms of the MCH level than in the PG level. So here you just need to be aware of what is the risk stratification that these patients come under, and this particular patient comes under the high risk variety. P16 positivity here, actually, what you need to be aware is that P16, usually we look for P16 diffuse block positivity. That means there is presence of the P16 reagent is taken up by the cells both in the nucleus as well as in the cytoplasm, and all of the cells are taking this up. So this is what we call as diffuse block positivity, and this is usually a sign of an HPV associated malignancy, and that is usually seen in cervical cancer, whereas in any high grade kind of cancer, be it cervical or even endometrial, P16 gets actually upregulated. So there is increased expression of P16 in any high grade kind of a lesion. So maybe our previous case actually showed that there is a tendency for a high grade it to be a high grade lesion. That is why the P16 is positive, and it does not mean that there is it is a cervical cancer or HPV association there. So unless you have a uh, wording of it, P16 diffuse block positivity, we don't consider this as an HPV associated cancer. Coming to the next question, this is actually a post-operative question. This is a patient who has undergone a staging laparotomy for CA ovary, and on post-operative day 3, she developed abdominal distension, for which we did and vomiting, for which we did an X-ray erect look, and we have the finding of multiple air fluid levels. So what is the diagnosis? So usually you'll get dilated bowel loops and with multiple air fluid levels. When you take an abdominal X-ray erect is what you actually do. In any patient who has a postoperative abdominal distension, taking this X-ray erect is again important, because the positioning of the bowel loops for its air fluid levels is again important. And at the same time, when you look for air under diaphragm, so you have the liver here, sorry, you have that diaphragm with the lungs here, and then the liver shadow might be here, and you will see a radiolucent area here, which denotes the area under the diaphragm. Usually after post-surgery, especially in open abdominal surgery, you might have some amount of air under the diaphragm, but then significant amount of air under diaphragm, you might have to again think about any perforation of the viscus there. But here, you instead of air under diaphragm, you are getting multiple air fluid levels. This could actually show that there is actually low bowel movements or absent peristalsis that is actually causing the bowel contents to actually accumulate there, and that is actually producing the air fluid levels. On a day 3, unless you have a question of there is a particular transition point that is mostly evident when you take a CT also. You have multiple dilated bowel loops, and then you have a transition point after which all the bowel loops are narrow. So this single point of transition is called a transition point, and that actually denotes a area of bowel obstruction. But then as long as that is not there in your question and she is having an abdominal distension, vomiting, and with multiple air fluid levels after a major surgery like a staging laparotomy, that is mostly pertaining to paralytic ileus. Paralytic ileus, again, due to bowel handling or due to loss of electrolytes in the form of hypokalemia, this can actually aggravate the paralytic ileus, and you actually treat them conservatively. Unlike for a bowel obstruction that is actually causing massive bowel dilatation, and you might have to intervene to correct the bowel obstruction. And you don't usually get to see obvious bowel obstruction or adhesive obstruction on the third day itself. So again, the post-operative day is actually clinching a diagnosis of a paralytic ileus rather than an obstructive cause there. So post-operative day 3, abdominal distension, vomiting, multiple air fluid levels, you'll think in terms of paralytic ileus. You treat paralytic ileus, mostly they are treated conservatively or expectantly, where you keep the patient nilperorally and with IV fluids. Sometimes you might even put in a Ryle's tube to actually decompress, especially you have a distended stomach in these cases, to prevent excessive vomiting and also aspiration pneumonia. You actually put in a Ryle's tube there and to decompress the bowel contents. And along with the IV fluids, you correct the electrolyte abnormalities, especially the hypokalemia is actually corrected. And over a period of time, the bowel actually regains its motility, and then the patient can actually start tolerating oral feeds again. So that is paralytic ileus you have there. Now you have pelvic radiotherapy is being planned for a young patient where to reposition ovary. Again, this is again a concept of ovarian transposition. This is especially important in those patients who are undergoing pelvic RT for any indication, not only for CA cervix, also even a case of CA rectum. If the patient is going to undergo a uh, radiation therapy to the pelvis, the ovaries are very much sensitive to pelvic RT, and overall pelvic RT of at least 20 gray will actually sterilize the ovaries. So to preserve ovarian function, there is one of the possibilities is to actually transpose the ovaries. You change the position of the ovaries beyond the radiation field. So again, what you need to be aware of that is the usual radiation field that is actually put forth, especially in the standard 4-box principle. In the AP, you have L4, L5, and the sacrum. So the L4, L5 interspace superiorly. Inferiorly, you have the obturator foramen, the lower border of the obturator foramen as the inferior limit. And then laterally, you have 1.5 centimeters lateral to the pelvic brim. So your pelvic brim is actually at the level of the sacral promontory, and your field actually starts at least 2 to 3 centimeters beyond the sacral promontory. So you have to transpose the ovaries beyond this pelvic field, pelvic RT field, to actually safeguard it from the problematic effects of the radiation. So for that, you actually transpose them 4 to 5 centimeters above the pelvic brim. Again, you have the psoas muscle coming down laterally, and you have the major vessels coming down, and you have the ovarian vessels reaching up to the ovaries, and you have the uterus, the ovarian ligament to which the ovaries are attached to the uterus. What you do is you transect the uterovarian ligament, dissect the infundibular pelvic ligament, take the ovaries up and then suture it to the peritoneum there. So it can either be lateral or medial to the psoas, but the major important part is actually moving it cranially as far as possible beyond the pelvic artery field, and you attach it to the peritoneum, either closer to the paracolic gutter peritoneum or over the psoas muscle peritoneum, and also you apply clips over the attachment of the ovaries to the peritoneum, so that these can be demonstrated when you do take the x-rays or CTs. So the clip areas would actually denote the area where the ovaries are present. So again, when you look at menstrual function, that is the most important part, or at least the ovarian function for the hormonal effects is what is actually preserved mostly when you transpose the ovaries. But then the live birth rate and clinical pregnancy rate might be much lesser in these patients, especially when you have a uterus that is getting irradiated. And then for that uterus to actually carry a pregnancy to term is actually going to be difficult. But then at least the ovarian function can be actually retained. And around 60 to 80% of the ovarian function is actually retained. Again, depends upon what is the pelvic artery field that is being kept. And also there is a danger for these scatter radiations beyond the pelvic field to actually even affect the ovarian function. But keeping these in mind, and while counseling the patient, we can actually take these patients up for the transposition of the ovary to a higher position, craniolaterally to its or from its present position. It can be done usually laparoscopically just prior to the planning of the artery. Now next you have a postmenopausal woman with HSIL on LBC. So here liquid-based cytology, that means she has undergone a primary screening modality of the liquid-based cytology, and you have got HSIL on the cytology part of it. So what is the further management here? Once you have an abnormal cytology, the next mode of management is actually patient should be taken for a colposcopy. So, but then we don't have an option of colposcopy here. I'm not sure whether that was present in the actual exam as such. So if there is an option of colposcopy, definitely that would be the next management there. But again, HSIL, especially HPV 16 positive, when you have done a liquid-based cytology, and if there has been a co-testing done or a reflex cytology has been done, and if it is HPV 16 especially, these under the ASCCP 2019 guidelines actually require an immediate expedited treatment. So even with your screening modality, if you have a condition which is having a very high risk of harboring a precancerous or cancerous lesion, rather than going in for an intermediate step of a colposcopy and biopsy, remember it is actually a cytology that you have done. You need to actually confirm it with a biopsy, and then you actually take them for treatment. So sometimes when you have these kinds of high risk entities, you can expedite the treatment without the intervening biopsy there. So then when you expedite this treatment, you can either take these patients up for the treatment right away. That is something that is also called as see and treat approach. Okay. And you have actually taken these patients for treatment, and the treatment usually that they should undergo is not an ablative treatment but an excisional treatment, because these are high risk lesions. You need to get because you have not taken an intervening what do you say, biopsy there, then the next option would definitely be an excisional treatment, because if you do an ablational treatment there, you will not get any tissue for diagnosis. So if you don't have colposcopy as an intervening step there for an HSIL, the next best step is always an excisional treatment. Now again, you have this option of hysterectomy there. You would not actually advise a hysterectomy directly for a patient unless the patient has got some other indications for hysterectomy other than this. So just being a postmenopausal woman with HSIL, directly you will not be taking these patients for hysterectomy. That is basically for two reasons. One is, many a times for the HSIL alone, you need to actually biopsy, histologically prove that this is only HSIL and nothing more or nothing less. So then then definitely hysterectomy is going to be an over treatment in these patients. So you don't have to do a hysterectomy even if the biopsy report comes as HSIL. You have got different modalities of treatment then and there. And if you already have an HSIL and if this patient is harboring an invasive cancer and you never knew that, because just by looking at the diagnosis of HSIL, you took up the patient for hysterectomy, and in the final hysterectomy, it comes out as invasive cancer. You should have actually taken up this patient for a radical hysterectomy and a lymph node dissection. So in that condition, your hysterectomy becomes an under treatment. So both these conditions can be there. So always an HSIL on cytology requires a biopsy proof, and following this you can have the excisional treatment. Or if you have a biopsy proof and all the criteria of ablation are actually satisfied and there is no suspicion of invasion, then you can even do an ablative procedure in them. But then in a postmenopausal woman, you actually prefer a excisional therapy, and you have again two options of excision left in the options that you can see. One is LEAP and the other is conization. These are both excisional procedures. So again, I'm not sure whether both of these were actually present in the actual choices. But then if you are forced to choose between these two as excisional procedures, please think that postmenopausal ladies, the transformation zone might be more inward into the endocervical canal. So here you have the cervix. This is the ectocervix. And in the reproductive age group, you have the ectocervix and the endocervix, that is the squamous epithelium and the columnar epithelium, and the entire transformation zone might be present on the ectocervix. So fully visible SCJ or the type 1 transformation zone. As the patient becomes menopausal and due to the deficiency of estrogen in her, the squamocolumnar junction actually gets pulled into the endocervical canal. Then you might have a type 2 or type 3 transformation zone. So in these conditions, you can still take the entire excision using a leap. For that, you have different modalities like the type 2 excision and a type 3 leap excision. But then a more foolproof method for getting the entire transformation zone which is regressed or receded into the endocervical canal, that would be conization in that sense. So if you have a high grade kind of a lesion in a postmenopausal woman where you expect that the squamocolumnar junction has receded way back in the endocervical canal, then a better choice would be conization if you are actually forced to actually choose between LEAP as well versus the conization. Now, next you have a 60-year-old lady with a postmenopausal bleeding and atrophic endometrium on biopsy. So, postmenopausal bleeding, you require an endometrial biopsy to actually rule out any endometrial malignancy. And you already got an atrophic endometrium. So, the senile endometritis or the atrophic endometritis might have been the reason back then. And now she has been started on estrogen replacement therapy for 3 months. Now she is still bleeding. So again, for our purpose, we always have to rule out the presence of any endometrial lesions, especially any malignant or pre-malignant lesion. So rather than reassuring her or continuing her on estrogen therapy, what we need to evaluate is what if we have actually missed out on any focal lesions. So usually the endometrial biopsy that we do is the endometrial sampling by Pipel biopsy, and that is actually, it looks at the generalized kind of a biopsy of the endometrium. So unless there is a generalized pathology in the endometrium, you might not get it in your Pipel biopsy. So if the patient is harboring a focal kind of a lesion, the next mode of diagnosis for that would be hysteroscopy, and you do a hysteroscopy, evaluate the entire endometrial cavity, and if there are any focal lesions, you'll have to take a biopsy from there, and then you can proceed only after that based upon what is the diagnosis that you get from a hysteroscopic biopsy. So hysteroscopy is actually one of the modalities that you need to actually use when you have a patient who has had an endometrial biopsy and normal endometrial biopsy, and she's got recurrent bleeding, and you need to evaluate her further with hysteroscopy. Okay, now this is a patient who has undergone a cervical conization, and she is stage 1A, free margin and no LVSI. This is very similar to the question that we discussed earlier. So now this is 1A, cervical free margin. It could be 1A1 or even 1A2 with a free margin and no LVSI. So the lack of LVSI is actually something that we can actually hold back and maybe do away with the node dissection as such, or at least observe her. So we can actually observe her based upon these findings. You don't require any adjuvant treatment for a patient who has already had a free margin and no LVSI. You don't have to do a re-surgery, because if there is a margin positivity, you might have to either do a re-excision, or if possible, this is actually a cervical conization. It's not in a pregnant patient. This is cervical conization itself is actually a treatment for those patients who are actually 1A1 without LVSI. You can actually keep them under follow-up. Once they are harboring LVSI, and always remember this LVSI is nothing but lymphovascular space invasion, and you don't get this on a cervical punch biopsy or the corpuscopic directed biopsy. You will not get the diagnosis of LVSI, because you need to have a good amount of stroma also when you actually look for LVSI under the microscope. And when do you get this adequate stroma is when you have a cone or a leaf specimen. So actually, ideally, you need to have a conization or a leaf specimen to actually comment upon LVSI. And if the LVSI are actually positive, then you need the evaluation of the lymph nodes also in that particular patient. But anyways, none of this is present in this patient, and she is a microinvasive cervical cancer. So conization itself is a treatment. Like both diagnosis and treatment is possible with this. So this patient needs to be kept only under observation. Now you have a complete mole. What is a karyotype? If you remember those differences between complete and partial mole and the karyotype, it's rather easy to answer this question. And you know that this is a patient who is already having IHCs which are P53 negative. It's actually, I think it is P57 that is actually mentioned, and then Ki67 negative. So again, this is these are lesions that are having what do you say? It is an empty ovum gets fertilized by a haploid sperm, and they undergo endoreduplication. So whatever um, chromosomal material or genetic material that is present, that is both from the paternal origin and no contribution from the maternal side. That is the characteristic of complete mole. So it is diploid and it is entirely paternal. And again, the P57 KIP2 is actually paternally imprinted and maternally expressed. Fine. Paternally imprinted, that means suppressed, and maternally expressed. So if there is no maternal contribution in the genetic material, usually those tumors or the cells will actually be P57 negative. So again, there is no contribution from the maternal side, so the P57 will be negative in a complete mole, whereas in a partial mole, you already have a haploid egg which is actually getting fertilized by two sperms, and this results in actually triploidy. And here, when you put in the P57, because there is maternal contribution also, the P57 would actually become positive. So again, to differentiate between complete mole, partial mole, and a hydropic abortion. That means this is just a normal karyotype pregnancy that got aborted, and it had hydropic changes which mimics the hydatidiform mole. So this is diploid, only paternal. This is triploid, This is again diploid, but it has both paternal and maternal contributions. So 46XX, 69XX, this could be again 46XX. But then this would be P57 negative because totally paternal in origin, but the karyotype is this, and just based on the karyotype you can actually differentiate between complete and partial mole, and also P57 will be positive in terms of partial because of the contribution from the maternal side. But then if you get a karyotype 46XX, both of these are actually looking similar, but here the P57 would be positive. That means a diploid karyotype with P57 positive means there is a maternal contribution. So that is not a complete mole. This is actually a hydropic gestation that got aborted. Now, the ovarian tumor and 20-year-old female with the best prognosis. So the best prognosis among germ cell tumors, always remember it is the dysgerminoma. Okay. All of these are actually um, germ cell tumors, especially malignant germ cell tumors, of which the best prognosis is with dysgerminoma. The worst would be with the endodermal sinus tumor or the yolk sac tumor, or even the mixed germ cell tumors with endodermal sinus tumors, or the embryonal carcinoma could also be one of the worst prognosis kind of germ cell tumors. And again, a post-op question is for post-op atelectasis, what is the best preoperative prevention? Always remember it is the incentive spirometry. You know the patient is given exercise in the form of incentive spirometry. That is, the patient inhales. It's actually an apparatus or device with a inhalational mouthpiece, and there are 3 balls within to actually incentivize the breathing that she requires. So as she inhales air, sequentially these balls would get lifted up, and she is asked to actually inhale and hold her breath as long as she is able to keep these balls higher up in their columns, and this would actually give her the incentive to take adequate breathing exercise rather than just asking her to take deep breaths as a separate exercise. This would actually benefit her. This actually recruits more of the alveoli towards her respiration, and this actually prevents the other basal atelectasis that is possible after she undergoes the treatment. So this is something that forms part of what you call as the of the ERAS components. This is prehabilitation. So you actually advise the patient to undergo at least a week or 2 of incentive spirometry prior to the surgery so that she gets a better functional outcome and she gets a more rapid recovery after her surgery, especially regarding the reduction of respiratory related complications. So incentive spirometry is the answer for this. You come across a lot of ERAS questions also in this, so that is actually a good thing to follow in detail about what are the ERAS protocols for surgery in gynec. Now, in this patient, in a young female, 2 weeks prior to chemotherapy, she is a lady who is going to undergo chemotherapy. It could be for anything. It could even be for a breast cancer or maybe for some hematological cancers. She is a patient who has to undergo chemotherapy. And as you see different options here, this could be something where what can be done to actually preserve her fertility before the patient undergoes chemotherapy. So please remember, it is the chemotherapeutic agents that is given for breast cancer and the hematological cancers like leukemias. These are the most gonadotoxic. So the ovarian toxicity is much higher for the chemotherapeutic agents that are used in these, and the comparatively less gonadotoxic are the ones that we actually use as adjuvant treatment for the germ cell tumors. So the chances of patients going in for an ovarian failure is much higher when the patient undergoes chemotherapy for other indications like breast cancer or hematological cancers. And again, if you don't have adequate time for this patient, so at least you need a gap of at least 3 weeks, 3 to 4 weeks before the patient can undergo chemotherapy. If you have that kind of a liberty to take that much amount of gap, then you can do what is called as the controlled ovarian stimulation, quick start stimulation. So in this, which one is best for a young female 2 weeks prior to chemotherapy? So patients, especially young patients, the indication for chemotherapy in them could be many, not it need not be always a gynecological cancer per se. It could be due to for a breast cancer or even for a hematological cancer. So what we need to be aware of is that the chemotherapeutic agents that are used for breast cancer as well as hematological cancers are more gonadotoxic compared to the chemotherapeutic agents that we use for the ovarian germ cell tumors. So the chance for of ovarian failure and then later on affecting fertility potential is much higher for these highly gonadotoxic chemo regimes. So if a patient comes to us as part of the fertility evaluation and fertility preservation prior to the chemotherapy, because once you give the chemotherapy and the effect of that is already happening on the ovaries, then the ovarian reserve would be very much less. So prior to that, can you do something to actually preserve the fertility potential? So if you have some amount of time, like at least 3 to 4 weeks as a gap prior to starting the chemotherapy, then you can actually do a controlled ovarian stimulation and then get the oocytes as you do in the any ART procedure, and you can preserve the oocytes per se, but you need at least 3 weeks of time for that. You can start a random start or a quick start kind of a stimulation. You don't have to wait for the particular day of the menstrual cycle. You can start it on any day and then give the adequate stimulation and the trigger, and you pick up the oocytes and preserve them. And then after she completes her chemotherapy and all, she can actually use these oocytes to actually for her later on pregnancies. But then if you don't have adequate time like that, as in this case, you have only just 2 weeks, she has come to you just 2 weeks before chemotherapy asking about any option of uh, stimulation, that is chemotherapy, or fertility preservation. In that condition, she might have to go for maybe an ovarian tissue cryopreservation. This is something that is not very rampantly available, but then theoretically, for your exam purpose, the ovarian tissue cryopreservation is done in those patients who have very less time gap between your fertility preservation measure and the chemotherapy. That is one. Then the other would be in you could say who are actually young individuals who are not reproductively mature. So any girl who has actually not attained her menarche, you might not be able to stimulate and get oocytes in her. In those conditions also, you might have to take the ovarian tissue directly for cryopreservation. The next question is uh, a little higher level kind of a question, if you ask me. Patient is already on multi-dose methotrexate. So, and even after the third dose, beta HCG didn't decrease by less than 15%. What is to be done? So, again, if a patient is already on methotrexate and there is no adequate decrease for at least three. So the after the third dose also, you have got 3 levels of plateauing is what they're trying to mention is. That means you are actually going in for a resistance to the methotrexate treatment. So when you have that kind of a condition, I'm not sure about the options that they have given here. So that is why I think what is actually being intended in these questions. Usually, when we have a multi-dose regime of methotrexate and the patient is not responding to that, the resistance is actually measured again by the plateauing or the rise of methotrexate of HCG levels. If you have 2 rises or again 3 plateaus, then again what you might have to do is you will have to re-image her, find out her risk scoring, and again those patients who have not responded to methotrexate, you have one more single agent chemotherapy, which is actinomycin D. So, and you can change over from methotrexate to actinomycin D. And again, you have the additional condition that have been mentioned in the guidelines is that if your final beta HCG has been less than 1000 IU, then these patients respond much better to actinomycin D. But then, if at the time of the patient's what do you say plateau, if the baseline HCG has been above 1000 IUs, then a multi-agent, that is the IMACO regime kind of multiple agents chemotherapy is what would be more beneficial for patients who have been resistant on methotrexate. So again, one single agent resistant, you have the next single agent. So maybe this high dose of single agent chemotherapy might be what is actually being mentioned here. But then, if the baseline HCG itself is very high compared to what we feel would not be covered adequately by the actinomycin D, then you might even think of changing right away from the methotrexate to a multi-agent chemotherapy. But at this level, I think what they are trying to say is to switch over to change to the next single agent chemotherapy, which is actinomycin D. And you have a case scenario where the patient is having hydatidiform mole, but the UPT is negative. These kinds of questions are very, again, favorites for examiners, where you have false positive and false negative HCG assays. So when you have highlighted mole means you actually have high levels of HCG, beta HCG. If you look at her serum beta HCG, it might be around 1 lakh, 1.5 lakhs, but still her UPT is negative. Again, that is some problem with the assay. The problem here is what is called the hook effect. So the receptors that are present within the test system, they are actually overwhelmed by the amount of antigen or the beta HCG that is already present in the urine sample. So when these receptors get overwhelmed, they actually give back a negative kind of a test result. So again, what you can do is you can actually bring down the concentration of this amount of this antigen in dilutions, and a more diluted sample, when you subject this test to the diluted sample, you might get a positive result, and that is what is called a hook effect. The heterophile antibody test antibody is something which actually cross reacts with that of HCG, and that is when you actually get a false positive HCG when you have a patient who's has been treated, there is no active disease in her, but then you still have low values of elevated HCGs in her serum. Then you might have to change the test assay, and which does not actually pick up these heterophile antibodies, and maybe you might get a different result then. So these are different false positive as well as false negative test results for HCG. And then you have sentinel lymph node biopsy guidelines or the algorithm for cervical cancer. What is actually mentioned in the algorithm, especially what we follow, is the NCC and the National Comprehensive Cancer Network algorithm. This algorithm is followed for both CA endometrium as well as CA cervix. So I'm not sure about what are the other options in this particular question. But even then, as we know, the 3 o'clock and 9 o'clock positions are the site for the descending cervical arteries, because we are not injecting the dye are not actually given as injections into the paracervical area. They are actually given intracervically onto the ectocervix. So the chances of injuring the vessels right there is actually not that high. So if you give a 2-site injection, you actually give the injections at 3 o'clock and 9 o'clock as per the algorithm, or you can give a 4-quadrant which is again 12, 6, and 3 and 9. So this is the 4-quadrant or the 2-quadrant, both actually include the 3 and 9 o'clock positions. So the position wise, we still give at the 3 and 9 o'clock position, and we do not actually avoid um, the 3 and 9 o'clock position, thinking that you will actually avoid the descending cervical artery, because these are again intracervical injections onto the ectocervix. Then the other things that might have been part of the question is, for sentinel lymph node biopsy in cervical cancer, the tumor size should be less than 2 centimeters. And again, ICG is actually preferred. And then you have to look at both hemipelvises, and there should be mapped sentinel nodes on each hemipelvis. And in case if there is no mapping on any particular hemipelvis, you will have to do a pelvic lymphadenectomy in that particular hemipelvis. So you got on the right side, you got a green looking node. On the left side, you didn't get any. Then you might have to do the pelvic lymphadenectomy in that area entirely. So that is one of the things. And then for the European guidelines, there is also an option of sending the the sentinel lymph node of cervical cancer for frozen section. This is just to find if they are actually positive on frozen section, you have to abandon the hysterectomy, radical hysterectomy in that condition. And then the same node that has been sent for frozen section, you have to then again subject this to ultra staging. This is to get the micrometastasis within them. So these are the usual guidelines for SLN in cervical cancer. So because I'm not aware of the other options in the question, or whether the question itself was whether all are true except, so then this would have been the wrong statement there. So with that we come to the conclusion of the NEET-SS discussion.